Good afternoon, and thank you for joining RadSite's webinar, Cone Beam CT Imaging Overview. Before we begin, I would like to go over a few housekeeping items. Today's presentation will be recorded, and an email containing the link will be sent to all registered participants early next week. To minimize noise and distractions, all attendees' phones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using the chat box section on the lower right side of the website portal. We will do our best to address all questions and comments at the end of the presentation. I will now turn the presentation over to our moderator, Dr. Elliot Siegel, Chair of RadSite's Standards Committee and Chief Technology Officer.
Great, thanks, Julie. I appreciate it, and I'm really excited today to be able to moderate this Cone Beam CT Imaging Overview webinar. There are so many questions and controversies and areas of lack of knowledge and excitement about Cone Beam CT, and lots of questions about it in so many different areas. So I'm really privileged and really delighted to have a trio of incredibly knowledgeable speakers, and I'm really looking forward to the presentations. We have John or Ian Yorkston, and Dr. Yorkston is a senior research scientist at Carestream Health. We've got David Lewick, who is Vice President of Tungsten Medical Network. And finally, we have Jenna Roller, PAC, Clinical Application Specialist for CurveBeam. And with the three of them, we're going to be covering a wide variety of topics that they have expertise and experience in. Next slide, please. And so what are some of the topics that we're hoping to cover regarding Cone Beam? And so, I personally have a lot of questions that I get from colleagues, and certainly RadSite gets a lot of questions about Cone Beam in general. And so we wanted to kick things off with a discussion of sort of an overview of what is Cone Beam and what is the scope. One of the questions that people have is, well, what's the difference between Cone Beam CT and traditional CT? In many ways, people have treated Cone Beam CT as just a subset or another CT scanner, but there are some basic major differences with regard to the physics and also implementation, and some things that we can do with Cone Beam CT that you just can't do easily with a multi-detector CT. So understanding the physics, advantages, disadvantages, limitations, and areas where Cone Beam CT might excel will be part of our discussion. Also, another question is, well, what are the indications for Cone Beam CT? What are the reasons that one would do it? How does one know when to do a conventional CT versus Cone Beam CT versus conventional radiographs, and where are we going? It's been suggested that we are moving in the direction from conventional radiography toward CT. What sort of role will Cone Beam play in that, and who's essentially doing Cone Beam and why? The other question that's really critical, and it's a major purchasing decision by folks who are contemplating Cone Beam, and a major challenge for those who have it, are questions about accreditation for Cone Beam and also regulatory issues. What are state regulations? What are reimbursement issues? This idea of, what does CMS reimburse? What are issues from payers with regard to Cone Beam CT? And then where's Cone Beam CT going in the future past the year 2020, and where has it been? So it's a lot of information to cover, and we're going to have some really great focused talks and discussion on some of those coming up. So what I'd like to do now is turn things over to Gary Carneal, who's going to talk about RadSite as an accreditation organization and give you a little background on that. So Gary?
Thank you, Dr. Siegel. Yes, my name is Gary Carneal, and I've had the opportunity to serve as the president and CEO of RadSite for the past decade, and it's been an amazing experience. RadSite has which is sponsoring the webinar today, has a long history in kind of the quality benchmarking arena for imaging. RadSite was founded as part of a program under an RBM in 2005, and during the first 7 or 8 years of its existence, actually was able to go in and certify over 60,000 pieces of equipment in 25,000 different locations, both for low-tech and high-tech. So when we moved forward and became an independent organization in 2010, 10 years ago, we had a rich history of kind of understanding some of the dynamics of imaging systems and workflows around those imaging systems, and eventually ended up being recognized by CMS as the 4th accreditation organization under MIPA in 2013. So since then, we've continued to grow in the marketplace to not only accredit advanced diagnostic imaging systems, but as you'll hear about today a little bit, to develop specialty standards geared towards, in this case, cone beam CT imaging. Of course, our overall mission is to promote quality, to really identify issues of patient safety, to reduce errors. Part of the joy of working with RadSite is with over 50 committee volunteers. We have the traditional MIPA Accreditation Standards Committee, we have the Cone Beam CT Standards Committee and Accreditation Committee, and a board, and it's just such an honor to work with different stakeholders to really try to identify the right standards, to calibrate those standards and the accreditation process, to really provide a ability to provide feedback loops to raise the practice of imaging, and to create that community with payers and others to really talk about what we can do next to improve the experience. In addition, we try to communicate and share, best practices beyond accreditation. This webinar is one of them where we're really not talking about the specifics of an accreditation program, but really kind of an emerging technology, that being cone beam CT, as Dr. Siegel referenced. Next slide, please. So we've actually been thinking long and hard about cone beam CT for probably about 3 or 4 years. And we noticed that although the FDA regulates the introduction of cone beam CT equipment into the field, we were surprised that there really weren't higher fidelity standards out there. And as Dr. Siegel noted, it kind of sometimes was not fully understood. So we embarked on it's now a 2-year mission. We formed the Cone Beam CT Standards Committee. We hired some leading thought leaders and physicists in the field and began working on standards and physics requirements. And believe it or not, the committee's met actually 20 times over the past 2 years, and we're now currently beta testing the current Cone Beam CT standards, which we're hoping to roll out next month. And as you'll hear today, there's a lot of subspecialties under Cone Beam CT related to dental and some other medical areas. We will be launching the first set of standards, version 1.0, which will really focus on manufacturer physics requirements. And then today you'll hear a little bit about us moving to version 2.0, where there'll be potentially uniform physics testing requirements. But the goal here is really to leverage the opportunity where we can promote better clinical outcomes, provide the right image to the patient at the right time for their clinical diagnosis. And you'll hear today that there's certainly cases where cone beam CT imaging makes the most sense. So with that, I will turn over to Dr. Yorkston, who will be our first presenter today, to talk a little bit about his experiences. Dr. Yorkston.
Thank you, Gary. It's a pleasure to be part of the webinar today, and it's a pleasure to be part of the committee that's developing these standards. My name's Ian Yorkston, and I'm a research scientist at Carestream Health. And to start off, I would like to give a little bit of background about cone beam. I mean, these systems, although they're quite new, they are quite ubiquitous, and they're already used in many different clinical locations. They first really hit the mainstream in the mid-90s to early 2000s in the field of dentistry and orthodontics, where now they are standard of care. If anyone has kids, particularly for the American audience, when they get their braces fitted, as they typically do, they'll normally get a cone beam image to understand just how much the treatment has to move the teeth around and stuff. They were used intraoperatively for a while. Originally, they were based on image intensifier C-arms, and the distortions and different performance characteristics of the image intensifier meant that the image quality of the reconstructions wasn't that great. But they've been around in intraoperative environment for a long time. They are now transitioned over to flat panel detectors, and that move has improved the image quality, where they're a standard capability enabled in most of the in-room systems. They were also developed and implemented as standard of care now for radiation oncology treatment planning. Any new external beam radiation therapy machine will normally come with a cone beam system to allow treatment planning and targeting of the tumor, even as it moves within the patient as they breathe. And there is a relatively new development in mammography, where mammo cone beam is becoming a very common diagnostic tool. Maybe not so much in the US, but certainly in other countries around the world. But the development today I was going to concentrate on is the introduction of extremity point of care systems. Typically, these are designed for use in office practices or smaller areas, not so traditional radiation using facilities. They're designed, optimized for imaging of the extremities, such as hands, knees, and feet. And as such, because they're optimized for those anatomy, their image quality is quite excellent. They're traditionally lower cost than multi-detector CT systems, and they have a characteristic that they're very easy to install. Depending on local regulations, you typically don't need external shielding in the room, which is a significant cost if you're trying to implement a CT system. They have, up to this point, had lower patient absorbed dose than MDCT, although MDCT systems are pushing that gap down, and eventually they would probably be similar in dose. But right at the moment, the patient absorbed dose for cone beam is maybe 3 to 5 times less than a MDCT system. And they were designed to improve the patient workflow and improve the patient experience, in that traditionally, if you went to an orthopedic surgeon and they needed extra imaging, you'd be referred out to a hospital. You'd have to go, you get your radiology department appointment, maybe the week after, and then the week after that, you come back and the surgeon would tell you the prognosis. These systems are designed to be point of care, in that it's a one-stop shop. The patient comes in, the surgeon decides you need some imaging, they go along the corridor, get imaged, and within half an hour they're back in the surgeon's office looking at the image and being told what their treatment's going to be. There are 3 main companies with products on the market. There's Carestream, the one I work for, Curvebeam, and PlanMed. And they all have similar type systems, designed specifically for extremities. So what's the difference between these systems and traditional MDCT? A traditional MDCT system, the X-ray detector there is relatively narrow in extent along the patient's body. Consequently, it's called a fan beam configuration, and to get an extended portion of the body imaged, the X-ray tube and detector has to be rotated around the patient, as shown here in this small GIF. And as it's rotating at a relatively high speed, 3 or 4 revs a second, the patient is transported through the fan beam, and as a consequence, it's called spiral CT. In contrast to that, a cone beam system uses an area detector. So it's a much larger extent in the Z direction. And you get all the information in one rotation around the patient. That means that the system is significantly less complex to build. You don't need slip ring technology. As you saw in the little GIF there, you're rotating hundreds and hundreds of pounds worth of equipment that all has to be balanced and made safe for the patient. That's expensive. So cone beam systems tend to be less expensive, have smaller footprint than a traditional CT. The other consequence of the way that information is acquired, as in full beam versus spiral, is that the image spatial resolution is isotropic in cone beam, which means along the Z direction, it's the same resolution as in the XY direction. This is typically not the case in a standard CT, and this is an example of a cadaver taken with one of our research hospital colleagues on a traditional Siemens system and an early version of the on-site system. And you can see there's a significant improvement in the Z-axis spatial resolution.
So, Ian, could you just, I'm sorry to interrupt, but could you just translate a couple things for us? So sure. In one case, you're talking about 15 to 16 line pairs per centimeter. How does that translate to slice thickness for a CT? So if I were doing a CT protocol in a patient and I were doing the knee, what is the equivalent slice thickness? I would estimate it's maybe around 0.3 millimeters, but can you tell me approximately if I were doing reconstructions in, say, the axial plane, I would be able to reasonably do reconstructions at what slice thickness if I'm trying to compare one with the other?
So your eye for detail is very accurate, Dr. Siegel. What you're looking at there is a voxel size of 260 microns, so 0.26 millimeters in X, Y, and Z direction in the right-hand image.
Yeah, so which is significantly thinner than the collimation in traditional multi-detector CT scanners, which might be 0.625 or something on that order of magnitude. So we're talking potentially about 4 times the resolution.
4 times the resolution,
And that's one question.
You can see it.
Yeah,
go ahead.
And then, so thanks. That's really helpful. And then when you say lower absorbed dose, that's something that is somewhat controversial. In other words, when you talk about absorbed dose, are we talking about half the dose, 90%? And I know it varies because there's a huge variation with multi-detector CT. But if I'm doing a knee, can you maybe give me a little bit of an idea of the typical protocol that you would recommend, with your system in comparison to what I might use with my own CT scanner if I were doing a knee?
So there are 2 aspects of patient absorbed dose. One is the amount of X-rays the machine produces, which is determined by the technique you use, the KV and the total mass. The other is the patient positioning. These systems, the orthopedics targeted systems, they typically only image one limb. The curved beam has the ability to do bilateral imaging of the feet, but the PlanMed and the CareStream systems, they just image one knee or one foot or one hand. So depending on an institution's positioning protocol, right there, if they image both knees or both ankles, you're reducing the patient absorbed dose by half just from patient positioning. The other aspect is that because of I think it's just legacy techniques that are used for traditional CT. The amount of radiation that is a typical protocol for a hand or a knee generates probably 2 or 3 times the amount of radiation incident on the patient than a typical protocol for a cone beam. I'm not quite sure what PlanMed or curved beams typical protocols are, but ours are targeted something around 80 to 90 kV with maybe 30 mass total.
Yeah, so we're talking not a 10% or 20% reduction. We're talking about a 2-fold, 3-fold reduction in radiation as far as the traditional dose. Great, thanks. That's helpful for clarification and sort of comparing apples with apples. Let me let you go ahead to explain about weight-bearing and non-weight-bearing cone beam CT.
So one of the differentiating features of these systems compared to MDCT is their ability to provide true weight-bearing imaging of the feet and ankles and knees. These are two examples of a patient, an actual patient with imaged on our system, the on-site system, in a non-weight-bearing configuration. And then for comparison, this is the same patient under weight-bearing conditions. And you can quite easily see the clinically significant difference in the image. On the left, impingement, and on the right, joint narrowing associated with advanced osteoarthritis. So this weight-bearing capability is garnering significant attention in, most importantly at the moment, the foot and ankle and podiatry communities, where the discussion is whether this should be the standard of care going forward if you have the ability to image in these kind of configurations.
And one would have the option to image typically either weight-bearing or non-weight-bearing, or do a combination of the two with most of the systems that are out there. Is that correct?
That is correct. These
okay.
Weight-bearing and non-weight-bearing were taken on the same system of the same patient, a couple of minutes apart.
Thanks.
So another example of where cone beam is superior to the standard of care typically utilized at the moment is comparing against 2D radiography. Here's an example of a 57-year-old woman who had wrist trauma. The traditional workup is 2D projection X-rays that the radiologist couldn't see any evidence of a fracture, but the patient had real pain in the first row of the carpus. Here's the same patient imaged in 3D, and it's clear that there's a fracture of the triquetrum for this patient that was not visible in the X-ray. That level of clinical finding has a significant impact for the treatment of the patient. So again, just an example of how these high-resolution 3D scanners can improve over traditional current standard of care 2D imaging. Moving on a little bit from the clinical side of things to physics associated with cone beam and how it's different than traditional CT. One of the biggest differences is this a characteristic of the data reconstruction called the cone beam artifact. Now, this is an artifact that's been well known in cone beam imaging ever since its initial inception. And what you're looking at here on the left-hand side is what physicists call a diffuse phantom. It's basically a stack of DVDs separated by some plastic beads. And in the middle image, which is from a single source, so it's a single source reconstruction, you can see that the delineation of the DVD, as you move away from the central plane of rotation, this plane here is the central plane of rotation of the system. And as you move away, the delineation of the thickness of the DVD really degrades. To try and ameliorate that, we introduced our system to have 3 X-ray tubes positioned along the axis of the patient. And you can see the same phantom imaged with the 3 sources really, although it doesn't remove completely the cone beam artifact, it certainly helps it. The other advantage of having these multiple sources along the X-ray, the rotation axis, is that it increases the valid reconstruction volume by roughly 50%. So this is an example of how complex the physics testing of these different systems can become, and in a way that's quite different than MDCT. So just to finish up, these new point-of-care systems are becoming widely deployed in areas that are very different than the traditional radiology departments, out into dental offices and orthopedic practices that historically haven't had that much experience with 3D imaging. They provide excellent image quality, which will get better as the as the model-based iterative reconstruction and deep learning reconstruction approaches are introduced into the market. And their 3D data can improve diagnostic confidence and allow more accurate decisions. And this weight-bearing CT is slowly becoming the new standard of care in some areas of orthopedic practice. They allow for improved clinical workflow with same-day service. And one interesting aspect that we're finding from at least our orthopedic clients is that they provide enhanced patient education. If you look at this image up on the top right, that's actually a CT image, that's an X-ray image displayed in what's called, there's a new technique of 3D rendering called cinematic rendering. And it looks, quite frankly, like you've just stripped the soft tissue off and you're looking at a visible image of a bone. It's quite incredible when you see the capabilities that these guys are developing. And our orthopedic surgeon colleagues are saying that when they show these images to a patient in the office, they get much higher buy-in to the treatment that they're suggesting. So it's a side effect that it's improving patient retention for these surgeons and the hospitals that they work with. It's turning out to be quite a significant impact for them. In the future, these type of images are going to provide pre-surgical planning and post-operative evaluation and healing evaluation. The image down in the bottom right there is the same patient 6 weeks apart, showing the healing of an ankle fracture. Patient-specific instrumentations already available with 3D, what's called cut guides and 3D printed implants, and 3D templating is only a matter of time before that is introduced, where when a surgeon goes into a patient to do a procedure, they'll know exactly the size of the different total knee components, for example, or total ankle components that will fit that particular patient, and they won't have to have a huge range of components that they might use as is current practice today. One of the big differences, one of the big advancements is going to be the automatic data extraction of information around, for example, making measurements in the foot and ankle when someone stands on their ankle. How far do the different bones move from each other and how far do they rotate? This is a whole new area of clinically relevant information that the surgeons and radiologists are going to have at their fingertips, and they're only just starting to understand the clinical significance of that new capability. However, extremity these cone beam systems are different from MDCT systems. The existence of the cone beam artifact makes the characterization of the image quality throughout the volume, the reconstructed volume, somewhat complex. And one thing that I didn't have time to mention is that these systems, because they have large area detectors, are more sensitive to scattered radiation from the patient because of the tight confines that the detector is close to the patient's anatomy. You get more scattered radiation detected, and you have to be able to handle that accurately. How that manifests itself in the reconstructed volume is that your house field unit accuracy for these cone beam systems is maybe not quite as accurate as MDCT systems, where the scatter acceptance is much lower and they don't have quite as big an impact. But there are Monte Carlo approaches now to handle scatter and cone beam that are making the house field unit accuracy pretty close, if not identical, to MDCT, to the point where applications like bone mineral density evaluation are going to be possible in the not too distant future. These differences, I think, just lead to the understanding that while much of the testing of these systems is going to be similar to what you do with MDCT, they are going to have their own set of special tests and the acceptance threshold associated with the cone beam configuration compared to the MDCT. And that's why the RadSite work on developing acceptance criterion for cone beam specifically in all its manifestations, whether it's dental, facial-maxial, ENT, orthopedics, mammography, is going to be crucial. And I just leave you with this nice eye candy image. So this is an attempt just to show the importance of visualization. How do you present that 3D data? This is the same data from the same patient with 3 slightly different opacities and colorizations on for the data.
Thanks, Ian. And that was a great introduction. And I think that it's really important to underscore what Ian said as far as accreditation, and that is, I think that next generation of accreditation and where RadSite is going immediately is toward looking at developing mechanisms to be able to objectively evaluate cone beam systems and compare one to the other and have a uniform standard for measurement that goes across multiple different systems. So that was a great introduction to the scope and physics and some of the medical imaging in orthopedics. Thanks. And one of the areas that are emerging and really interesting and exciting is the area of cone beam CT for ENT care. And so, David, thanks so much for coming to give us a little bit of information and background on that, and also, crucially, some of the regulatory and revenue and reimbursement issues. So, David, thanks. Let you go ahead.
Absolutely. Thank you so much. My name is David Lewick with Tungsten Medical Network. Happy to be on the panel here today. Quick background about me. I got started relatively young. At 20 years old, I was a registered lobbyist working with physician groups in Michigan to obtain imaging equipment through the state's Certificate of Need regulations. And that started my background in CON as well as some experience with StarClaw, which I'll talk about in just a moment. After just a few years, I transitioned to a cone beam CT manufacturing company and worked in product management, sales, and executive leadership over the course of 9 years. And I authored user manuals and company processes. And now for the last 4 years, I've been working at Tungsten Medical, and we provide CT scanner sales, CT scanner service, accreditation support, physicist testing, and PACS access to scans and remote backup. In total, we've participated in hundreds of point-of-care CT installations across the country, specifically in ENT practices, and we've worked on hundreds of accreditation applications through the IAC, which has been the only option until now that RadSite will hopefully be releasing their standards very soon. And working with so many accreditation applications has given us this insight into what improvements can be made into the accreditation process, which we hope to implement, with RadSite, and that's why we're excited to be here. Some advantages of in-office imaging, specifically as it relates to ENT. First and foremost, the obvious one, I think, is to increase revenue. So on average, if you're referring out more than 15 scans a month, it tends to make sense to have a CT scanner in your office. The cost of these scanners are typically amortized over a 5-year period. Once the scanner is paid off, then there's significant revenue increases after that. And you can expect these scanners to last sometimes as much as 10 years, if not more, with some different upgrades that are available out there. Next is you can retain your patients. By keeping the patients in your office, you obviously can diagnose their disease in the same office visit. And that speaks to improving efficiency, which I'll talk about in just a moment. I think a common theme that you'll hear in any cone beam application is that there's going to be a dose savings. And that's absolutely the case within ENT use. There was a question earlier about what the dose savings might be in orthopedic or extremity use. In the case of ENT, on average, your dose savings is about 1/5 to 1/6 the dose for adults, and as much as 1/10 the dose for pediatric scans when you're comparing cone beam CT to a typical conventional CT scanner at the hospital.
So just to clarify that, when you say there's 1/5 or 1/6 dose saving, you don't mean the dose is reduced by 1/5 or 1/6. You mean that the dose is reduced by a factor of 5-fold or 6-fold to a total.
That's correct. Yeah.
Okay. Thanks.
That's correct.
Yep.
Yeah, CBCT is 1/5 the dose, or it's approximately 80% savings Using real numbers, you're comparing about 0.17 millisieverts for a typical ENT CT scan of the sinuses to around 1 millisievert, which is a similar CT scan on a conventional CT scanner. So a lot of different ways to compare, but absolutely a dose savings every time.
Yeah, and I should point out that is approximately the same dose as a lateral chest radiograph. So PA chest radiograph is 0.03 millisieverts, lateral chest radiograph 0.17, so 0.2. So we're talking about the CT scan, the ENT CT scan, approximately the same dose as a chest PA and lateral. Slightly lower.
It can be in some cases, right? It can be. So there's, like I said, a lot of different advantages to utilize dose more efficiently in cone beam.
Thanks.
And finally, thank you. Yeah, and finally, improving efficiency is a huge advantage for in-office CT imaging. By diagnosing the patient the same day they arrive in your office, the patients forego a second visit to the hospital for a CT scan, which I think now more than ever is probably more important. I've just recently read a lot of studies, given our current environment, that CT scanners at the hospitals are going to be potentially more utilized for lung CT scans. And having said that, CT scans, non-contrast CT scans for sinus will be triaged, and patients might not be able to get them as quickly. Certainly not as quickly as by having the CT scanner in your office. And of course, by eliminating that second visit, you can also eliminate the third follow-up visit that a patient would need to have in your office to start that treatment plan. So not everything is combined into one visit, and even by eliminating the follow-up visit, your practice can focus on more initial appointments with new patients, which is what improves efficiency. There are a lot of regulatory implications and requirements when it comes to implementing an in-office CT scanner. A lot of these vary by state, and I'll speak to some of these now. So first of which is certificate of need. Just by background, approximately 35 states have certificate of need regulations, and about 22 of them regulate CT. And of those that regulate CT, many of them have a dollar threshold below which, if you specifically have a cone beam CT scanner, the certificate of need process does not apply. Now, there's 3 states that it does apply to. So unfortunately, if you live in Michigan, Connecticut, or Virginia, there's going to be a certificate of need process to wade through. In our experience, we've been successful in Virginia, but it does add cost and a lot of time to the purchase. Michigan and Connecticut, unfortunately, are all but impossible. But again, this only applies to ENT. There a lot of certificate of need requirements are now. They have separate exceptions for dental, and then different requirements for different medical use. So that varies by state now. Next is Stark Law. A quick background about Stark Law. This comes up a lot for in-office CT. So Stark Law is a federal law that prohibits physicians from referring Medicare patients to entities they have a financial relationship with. There are 2 specific exceptions when Stark Law does not apply. And the first of which is called the in-office ancillary services exception. And in short, what that means is if you have a CT scanner in your office where the physician is sending out the referral, you can do it in your office, and Stark Law does not apply. The second exception is called personally performed procedure. And what that means is Stark Law doesn't apply if the physician pushes the button. We'll actually talk about who can push the button in just a moment. But that's another exception to Stark Law. So by and large, Stark Law does not apply for in-office cone beam CT for those 2 reasons. There's meaningful use requirements, specifically stage 2. This has a lot to do with EHR compatibility. In short, this regulation can be met by just having your CT images accessible through your EHR. A lot of different ways to do that, sort of depending on your EHR system, but by and large, it's relatively straightforward to meet this requirement now. I think the important thing is just to be aware of these requirements, which we obviously at Tungsten certainly are, and we'll help you wade through all of these things so you don't get caught up in any of them. And finally, and this comes up every single time we install a scanner, is who can push the button. This varies widely by state. Some states really don't have much regulation at all on this subject, which means anyone that is trained to safely operate the scanner can push the button. In some states, you have to have a state licensed, what they call technician, and I would put that word in quotes because that definition varies by state, but by and large, for the most part, it's relatively easy to get these state licensed certifications. You just have to maybe fill out some paperwork, potentially certify to some competency requirements, some additional training perhaps. In most states, or actually in all states, you can be a physician and you can push the button, or of course you can be a licensed radiologic technician. We don't recommend in this case to hire a licensed RT by and large, unless you're a very big practice and you have maybe over 10 locations and as many CT scanners. You could probably get away with having the physicians push the button. But again, we train all of the staff to safely operate the scanner, so you can position the patient and the physician is only present for the actual scan itself, which in most cases is less than 20 seconds. A lot of other small requirements, even things like your radiation signs, your radiation safety training, dosimeter badges, your backup of CT scans. All states have a specific, or many states have a specific registration form, or even physicist survey testing. And of course, we help you wade through all of these, but these are just things to consider. So when you're looking at a CT scanner for your office, you'll want to ask, what are the regulatory requirements, and make sure you're on top of all of those.
David, do in general people need to have shielding for these units, or is that one of the advantages in comparison to multi-detector, or does that vary from state to state? What percentage of these sites have shielding?
Actually, it doesn't necessarily vary state to state. It varies from specific room to room. So depending on the room that you want to utilize your CT scanner in, and depending on the utilization of adjacent rooms, we calculate the distance to ISO center of the CT scanner and can calculate exactly what shielding is needed before we install the scanner. So we provide a shielding plan, and in most cases, additional shielding is not required. In all cases, an operator barrier is required, and that's included with all of our installations.
Thanks. And you mentioned ENT applications for evaluating sinus disease, but are these systems also used for evaluating mastoids, base of skull, temporomandibular joints, and what percent of these units are doing sinus series versus some of those other indications?
Absolutely, that's a great question. So in our experience, we've seen that approximately 15% of the scans ordered from an ENT practice will be for a temporal bone scan, where you can evaluate mastoid and that kind of thing. Some cases, we have scanners that are placed in otology specific installations. So they would be utilizing the scanner 100% of the time for otology cases. Or even in the case of like Children's Hospital, for example, where they're doing 100% pediatric scans. So a lot of different applications for the same device.
And not just sinus disease. Good. I just wanted to emphasize that. Thanks.
Yeah, absolutely. And of course, we're all here to really understand, I think, the advantages of accreditation. I think first and foremost, the most important one is reimbursement. There's a lot of advantages to accreditation, but I start with the financial case first, because if it makes good financial business sense, then there's no reason not to do it. At this point, many major payers require accreditation in order to get reimbursed. Medicare, UnitedHealthcare, Humana, for example, require accreditation to get the full amount CT scan reimbursed. Jenna, who is going to follow after me, is going to speak specifically to some payers and specifically as it relates to prior authorization requirements. So I'm looking forward to her discussion on that as well. Of course, there's standardization, which is a very big advantage. So RadSite accreditation covers the practice, the staff, and the equipment. And so by having standard policies and procedures in place, all practices that receive accreditation are going to meet these requirements for each of these categories. So you can be, well assured that there's certain personnel qualifications, CT scanner performance qualifications as measured by quality control procedures, physicist surveys, and one of the unique advantages that RadSite is working on, which was discussed earlier, is this concept of using a standard phantom that can be used across all cone beam CT scanners to standardize the performance of different pieces of equipment. And we're really excited to see that. And finally, there's a marketing advantage. So you can market your practice, your physicians, and your equipment to, as accredited to your patients. And you can convey that you not only have the right tools and technology, but you've passed this third-party evaluation to meet certain quality thresholds. And that instills this confidence, not just with your technology and in yourself, but it's also instills it with your addressable market, and you should take credit for that.
Great, thank you
finally,
very much. Go ahead. Dave.
Yeah, absolutely. I'll just end by saying if you have any questions for me, I encourage you to ask them at the end of the webinar. If we run out of time, you can reach us at our website at tungstenmed.com. And Jenna's up next. She'll talk more about different medical applications and, as I said, include a specific section on payer reimbursement. Thank you.
Yeah, perfect. Thank you for giving a great intro and transition to Jenna Roller, who is from Curve Beam Clinical Application Specialist. And from her unique perspective, doing clinical applications, she's going to have a clinical emphasis on what she talks about. And then one really important topic I'm looking forward to hearing about more are decision points for selecting. How do you pick the right cone beam CT system? What are some of the characteristics that you're looking for? So, Jenna, looking forward to having you finish us off. Thanks.
Yeah, absolutely. Thank you guys for having me and inviting me. This has been a great group to work with. I have my background. I actually started in the public health arena, and so I was looking at larger population level interventions, and then actually transitioned to clinical medicine as a physician assistant and worked in orthopedics doing total joint replacement for about 5 or 6 years before joining Curve Beam. So that's kind of my path and how I got here, but it's really been a pleasure to get to know everybody in this group and work together on these standards. I think it's a great way to educate everybody. So we touched on this early, and I know Gary spoke to this list, but when we speak to specific medical applications and how cone beam is being implemented, these are all the specialty areas that RadSite has taken I really give them credit for their due diligence to specifically understand how these technologies are being used and implemented in all of these different specialty areas. So dental, maxillofacial, ENT, orthopedics, podiatry, mammography. Those are very different medical arenas, and they have taken a tremendous amount of detail in getting to know what the ins and outs are of those different areas and how this technology is becoming more and more valuable in each of those areas. So how are the medical professionals utilizing this technology? And this the cone beam CT scans that they take are actually ultimately being used for all of these different applications. So surgical planning, the scans can be imported into other specific software. And you can see an example in the top right corner of the dental application there, that they're able to get incredibly detailed surgical plans for screw placement and making sure that the depth and position of implants is not impacting any of the nerves that are running in the jaw. So having these tools in the office really takes their level of care to the next level. Ian mentioned this in regards to 3D printing, and here with the hand as an example. The cone beam scans can be taken and models can be made so that the surgeons can actually manipulate the anatomy and see how they are going to approach a patient's specific anatomy prior to getting into the operating room and getting into that case. This allows for a great level of collaboration between doctors and different specialties. And it's really changing how people look at very complex cases to improve their surgical approach and their efficiencies. Another area that the scans are used is in custom surgical instruments. So our company, Curvebeam, has specifically gotten into this recently. On the bottom right corner, these are the cut guides that Ian mentioned as well, to just further elaborate. These are the ones that are used for an ankle replacement. And what this allows the doctors to do is they can use these custom gut guides to each patient's specific anatomy so that they're getting the perfect cut and the perfect position of these implants much more reliably, with a higher degree of repeatability as well, so that the patients get a better outcome. And last but not least, the picture here of the knee replacement. We're hoping, and this is future applications, but we're working towards this now, is looking at actually being able to template for custom surgical implants and having that happen. We're currently doing that at Curvebeam in ankle replacement, but just steps that we're continuing to take further and further in the cone beam CT realm. So we've kind of all touched on this, but I thought I would really try to give more of the medical perspective on this point of care concept and just what this means more now than ever to everyone in terms of efficiencies and making one trip to the doctor's office in the current COVID-19 environment. But really just wanted to highlight some of the images. So at the top here, some dental in the mid region here, that's a breast exam. And then here, there's actually a foot here and a high heel to give you the level of detail that some of these systems can accomplish. But it really does allow for the clinician and the patient, I think, to reach a better understanding and a better agreement of the treatment plan for that specific patient. And I think in the long run, that's really going to mean a lot. But I don't want to harp on this, but it really does come down to better diagnostics for less radiation. It really does streamline the workflow in the office where you're not relying on outside imaging and the patient bringing it back. We've all been there and hoping the computer works well and that the disk loads and everything is seamless. And sometimes it is, and a number of times it's not. So this also allows for a tremendous amount of patient education. I think that's really the collaboration between the provider and the patient is really where you get the most effective treatment plan. And in addition, some of the applications I just mentioned previously, the more accurate your surgical planning has been shown to correlate to increased operating room efficiency as well. And I think we're looking more and more in that direction. Whoops. So Gary, here's your slide. But overall, it's hard to kind of keep this broad enough that it applies to all of the cone beam CT systems that are out there. But I tried to break this down so that for anyone who is out there and they are thinking about implementing this technology, I wanted to kind of give you an outline. If you're somebody who likes to get into Excel spreadsheets and really get your information organized, this might be a really good way to kind of outline what you're looking for so that you can make the decision that's best for you and your practice. And so when it comes to the device itself, specs are always important. You can want to make sure that it hits on certain parameters. But I think one of the most important questions to ask yourself is, does it serve your needs? So really assess your physician and patient mix. So what do they treat? What are their anatomy that needs to be imaged? And then also their procedures of interest. So I spoke to this previously, but not only what anatomy do you want to look at, but what do you want to be able to do with that information? What procedures, what surgeries, what treatment plans are going to be impacted by you having that additional information and that knowledge? Looking at installation and part of accreditation, want to take into consideration that there is physicist evaluation. David spoke to this as well, and just working with whoever your manufacturer is to evaluate your space and make sure that you're meeting those requirements. And then also taking a look at operator requirements. So this is really important when you're considering it. There is that state variability, and there is variability between devices as well and different medical specialties. So you just want to make sure that you educate yourself on that as well. Gary and the whole staff at RadSite has been really great about looking at a fine-tooth comb, what matters in terms of education and accreditation requirements, and making sure that we're keeping the highest of standards for the image quality and the safety of patients, but also appreciating the nuances of each specialty area. Images as a whole, I think it's really important to ask yourself about field of view. So how much anatomy do you want to cover? So do you want to be able to take small, medium, and large pictures? Do you need to be able to take bilateral imaging? Do you want to be able to take single unilateral imaging? And make sure that you ask those questions. Same thing about software, so acquisition software and how pictures are taken, and then visualization software about how you look at those images. Ask questions about upgrades, ask about software implications. Is there a charge for these things? And then look at integration. So same kind of thing about what do you want to do with these scans? So is there compatibility with other surgical software? There's some specialists that are very familiar with certain planning softwares, and you want to make sure that they're able to be integrated. The other thing you want to look at is, are there other vendors that have CT-based products that are really important to your practice? So like we've discussed, custom cut guides, instrumentation, implants. Make sure you do your homework on all the different people that are in your office that are going to utilize this technology. And then finally, I would take a look at service and warranty. So these are the little details you know, that you just want to make sure that you've addressed and you've asked those questions. So look at who provides service, national coverage, and then look into the different warranty options and packages for the different options that you have in front of you. And then finally, everyone's favorite topic, payer reimbursement and prior authorization. I joked with our group of panelists here the other day that I have spent plenty of time trying to do this myself personally when I was in clinical practice. So as I've worked to help others with it, accreditation, one of the biggest things is to really make sure that you have accreditation so that your authorization is not an issue for Medicare, and you can completely take care of that patient population without having to worry about it. And then just a note that this often does not apply to Medicare Advantage plans. That's a common question that comes up, and so that is just a little nuance that I wanted to point out. But for the commercial payers, the couple prior authorization tips I have when it comes specific to cone beam, but make sure that you utilize online portals. So you really want to avoid tying staff up on the phone and the fax as much as possible. Make sure your notes are completed in a timely manner so that your office staff has the ability to reference your information and what you documented clinically so that they can explain why scans are being ordered if they need to. Always include more than one diagnosis code. You don't want to have pain as the only reason that you're ordering this scan. You want to paint a better clinical picture of your rationale. You always want to note that recent or previous x-rays were reviewed. So you want to just make sure that you speak to any recent imaging that you've looked at and acknowledge that it was not sufficient to make a diagnosis or determine whether additional interventions were required. and evaluate implementing into chart prep. So this is a big one. It's a shift when you have a technology in your office that you were used to sending out for. And talk to staff. They're often your best resource on thinking about how do we change what we do for something that's now a service we provide versus sending them out. And then there is the ability to utilize stat requests when appropriate. So if there's any acute trauma or an acute injury that came in, usually if you utilize those within 24 hours, because it's an acute issue, most of the commercial payers will acknowledge that as well. So it's been a pleasure, and I'm really looking forward to the Q&A session here. Hopefully we have some good feedback, but thank you all very much.
Thanks, Jenna. That was terrific, and you covered so many different topics in such a concise way. Really appreciate that. One thing I wanted to mention was we've talked a little bit about some of the challenges with how cone beam CT is different from CT, different specifications, and also different questions, such as the question of who is able to push the button, variations from state to state. And so I just wanted to mention that there is a RadSite webinar that's going to be on June 17th that will cover RadSite cone beam CT standards and some of the ways that we've tried to translate all the wonderful information we've gotten here and from so many other sources into unique standards that cover and converge on cone beam per se. And so the participants there, Gary Carneal is going to moderate that, and we'll have William Harrell, Adam Powell, and then I will participate in that also. So just mark your calendars, 2 p.m. on June 17th. And I'd like to thank Jenna and David and Ian for doing a phenomenal job. I mean, I learned a lot, and it was really probably the best overview that I've ever heard of cone beam in a single session. So thanks so much. Julie, I'm going to turn it back over to you.
Thank you. And it is 3 o'clock, and we've got a ton of questions. So our hour is over. Gary, do you want us to answer any questions, or we'll reply to them?
Sure. Well, why don't you do one or two?
The first question I have is why you don't consider new Tom a CBCT for MSK?
So I guess I could take that question. So new Tom is a cone beam system. It's a full body scanner, and it's got a larger footprint than the systems I was showing, and it's kind of like the O-ring, the O-arm from Medtronic. It's a slightly different beast in that it's not point of care, but certainly it's a cone beam system, and that it uses a flat panel detector.
Yeah, they further ask, resolution is elevated by 3 since it's a voxel and not a pixel, isn't it? Question mark.
So there's a lot of confusion around about what is a voxel, what is a pixel. People typically use the term voxel for a 3-dimensional picture element and a pixel for a 2-dimensional picture element. That being said, when you take a 2D slice from a 3D data, you can talk about pixels in the scan. But typically the resolution of these cone beam systems is higher because the pixels on the flat panel detector that you're taking the projection images that are used to create the volume, they are smaller than the typical size of a detection element in an MDCT system. On these flat panel detectors, the pixels are typically somewhere in the range of 140 to 160 microns, and you might read them out 2 by 2, so a couple hundred microns in size. Whereas traditional MDCT, those detection elements are larger, like 0.5 millimeter or so. And But it's a complex question because you got magnification with MDCT, so yeah, it is very confusing.
Thanks, Ian. And then maybe we have time for just one more question, and then any other questions that we have, we can refer those to the speakers for later and send emails out with those questions. So, Julie, you want to do one more? I can't see the questions myself.
Sure. What percentage of cone beam CT studies in the U.S. are performed with intravenous
Contrast.
iodinated
Yeah, so,
contrast?
right. So my guess would be it's really small. How about from an ENT and a orthopedic perspective? ENT, what percentage of the cone beam studies are with contrast? I would have guessed a small percent, given that we're mainly looking at bony detail.
Yeah.
Yep, David.
I'm not aware of any percentage.
Yeah.
So I would say it's very, very
you guess
low.
less than 1% in your own experience.
Definitely. Yeah.
Yep. And then how about for ortho? So Jenna or Ian, are you aware of people using intravenous contrast in addition to the beautiful studies that you showed? Certainly there would be the potential, but my understanding is in general, cone beam CT systems are not being used with intravenous contrast. Is that correct?
So I would agree with that, Elliot. But depending on the country, for example, in France, intra-articular contrast is used quite commonly for like knee injuries and stuff. That's a different beast than injecting into the arteries or the veins. But so people do use contrast, but again, I've not seen it so common in the US.
Yeah, and I think a related question then would be, what is the time of acquisition, right? So for CT, one could potentially do an acquisition in less than 10 seconds or so. If one were doing a knee or lower extremity, then what would be the typical time to acquire? And that might have implications for contrast as well. So
most of these systems acquire in somewhere between 15 to 20, 25 seconds.
Okay.
It can take longer if you're trying to do a larger volume, a larger area. So you can't really do flow measurements of contrast, but intra-articular injections where the stuff dissipates through the joint. Yeah. You can
and Jenna, is that your perspective also?
Yeah, I can add to that. Recently, we've actually seen an uptick in this in orthopedics, specifically just due to Ian's mention of the intra-articular injection. Mm-hmm. So it's really convenient for the patients, and the technique is very similar to the same way that you would get a cortisone shot in a joint. So the technical kind of specialty is very familiar to all of the folks in orthopedics that are routinely doing these types of injections anyway. And they've been able to assess some additional indications with the intra-articular injections. So I've seen an uptick in it. I think as more and more people get comfortable with the technology in their office, it's something that they'll further explore. The part that I think is most interesting, and Gary's going to get back at me for this, but the part that's really nice is because it's intra-articular, the side effect profile is so much less. Yeah. So it's not a systemic exposure to contrast, and it's localized to the specific area of interest or injury. We've actually had some folks that have done studies looking at weight-bearing knees and utilizing contrast and comparing it to an MRI study. So I think in time it'll get further explored, but it was a great question, great point and commentary, and I can only echo Ian's point that it's very common in other areas. We've had French customers as well that have particularly reached out about the same.
Thanks. How about proportion of upper extremity versus lower extremity with cone beam systems in general? Would you say it's 5-to-1 lower extremity, or what's your experience been?
I would say there's a greater number of indications that people are looking for the weight-bearing aspect in the lower extremity. So there's a number of medical conditions where you're getting more information. Ian had some great images there to just show the significance of weight-bearing imaging in the lower extremity. But it's also really important for the upper extremity, particularly in the hand and wrist, where you have a lot of overlapping anatomy. And I will say anecdotally, a lot of our customers order it for the lower extremity people that want to look at it. They're certain that they'll use it. And then very soon there to follow are the upper extremity folks that are looking at a lot more trauma and planning for surgery, and they quickly jump on board. So in true numbers, the versatility of some of our systems lets them do both, and that's really nice as well. So
excellent. Thanks to all three of you for an extra. Oh, go ahead. Did you want to add something?
I was just going to echo Jenna's comment there that the main interest has been from the foot and ankle podiatry community, but for weight bearing specifically. But then as soon as the hand guys see the quality of the images, they jump on it too.
Good. Well, thank you, all three of you, for, as I said, an extraordinary session and one of the best I've heard, and for covering so many topics. And RadSite, thanks for sponsoring this webinar. We really appreciate it. Julie?
All right. So if you do have any questions, feel free to contact us at the phone number and or sales. Visit our website, radsitequality.com. Thank you. And just a reminder, look for our next webinar in a month. Thank you.
Thank you, Julie. Take care.
Bye.
Thanks, guys.
Stay healthy. Bye-bye. Thank you so much.
Thank you.
thank you.